Basic principles in administration of general anesthesia. Session objectives. At the end of this session, participants will be able to explain the components of general anesthesia, appreciate the challenges and recognize the complications, apply the preventive measures and appropriate management protocols. This is the session plan. Anesthesia is defined as reversible loss of consciousness. It can also be defined as reversible suppression of various modalities of nervous systems such as central nervous system or peripheral nervous system. General anesthesia means you are inducing an unconscious state. In regional anesthesia, otherwise also called as analgesia, the patient will be conscious. Only a part of body is anesthetized, like spinal and epidural, nerve plexus and individual nerve blocks, field blocks, and infiltration anesthesia. Historically, if you see, before the advent of invention of proper anesthesia techniques, the patient will suffer from pain during the surgical procedures. Then came a successful public demonstration of anesthesia by W.T.G. Morton. The surgeon is Collis Warren and the patient is Gilbert Abbott. The surgery done is tumor in the jaw excision. The inhalation agent used was ether. W.T.G. Morton was able to successfully demonstrate the anesthesia and the painless surgery in October 16, 1846. So this is celebrated as Ether Day. So ether is being an inhalational agent, which is being inhaled by the patient and undergoes unconscious state. Chloroform was the first used as an inhalation agent, then ether, then halothane. Now we have modern agents like isoflurane, sevoflurane, and desflurane. This is Simpson, who used chloroform successfully for 4,000 patients without a single death. He was well appreciated for that. He was also known for giving obstetric anesthesia, that is painless labor, for Queen Victoria. Usually chloroform is safe, but the death occurs due to sudden cardiac arrest by ventricular fibrillation, that is cardiac arrhythmias. So ether replaced the chloroform, and halothane and replaced the ether, and newer agents are being used now. Coming to the components of general anesthesia, it has mainly three components: induction, maintenance, and recovery, which can be compared to the takeoff, flight phase, and landing phase of traveling in an aeroplane. The pilots are the anesthetists. They are going to take care. So first phase is the induction. Inhalation anesthesia. Chloroform gives immediate induction. Ether, it takes 15 to 20 minutes. Halothane takes 5 to 10 minutes. Sevoflurane takes a very short duration, 2 to 4 minutes. While isoflurane and desflurane, they cannot be used as induction agents. They can be used as maintenance agents. When you consider recovery, chloroform, though the induction is immediate, the recovery is delayed. Ether, it is almost the same, 15 to 20 minutes. Halothane, it is almost 5 to 10 minutes. Sevoflurane, it is same, 2 to 4 minutes. Isoflurane and desflurane takes 5 to 15 minutes and 2 to 3 minutes. If you see, the desflurane is the resulting in rapid recovery, followed by sevoflurane. We also have intravenous drugs for induction. So the inhalation anesthesia takes more time, and it may be unpleasant in some agents like desflurane and isoflurane. We cannot use that. So instead, we use intravenous drugs like thiopentone, propofol, ketamine, etomidate. The effect is immediate. The patient goes for unconscious state within 15 to 60 seconds. That is one arm brain circulation. You are giving in one of the arms, the blood reaches the right side of the heart, then goes to the left side of the heart and reaches the brain within 15 to 60 seconds. But the difficulty is they are all short acting. So we cannot use that for maintenance. They are useful for induction, but we cannot use them for maintenance. Propofol can be used as a maintenance if it is given as an infusion. So what shall we do? So use the intravenous drugs for induction, that is like thiopentone, propofol, ketamine, and etomidate, and go for maintenance with inhalation agents like ether, nitrous oxide, halothane, isoflurane, sevoflurane, desflurane. Ether is not used now, halothane is not used now. So the nitrous oxide is the predominant agent we use. Halothane was used. Nowadays, halothane is not used. We use isoflurane, sevoflurane, and desflurane for the maintenance. In case of children, their lungs are very small. They are not miniature adults. They have a low functional residual capacity. So the induction is fast. So the inhalation agent's effect is quick. So we prefer inhalation agent induction in children. Previously, halothane was used. Now, halothane is not used. We use sevoflurane for pediatric induction. So what do you mean by co-induction? We use nitrous oxide oxygen or oxygen sevoflurane or all the three, nitrous oxide, oxygen, and CO, and then give IV induction. So you are inducing with both inhalation as well as intravenous induction. This is called co-induction. What is the advantage? So the intravenous agent dose can be reduced and hence the side effect can be reduced. So this is called co-induction. Then what we call it as the total intravenous anesthesia, TIVA. Here we use only intravenous drugs and oxygen. We don't use any inhalation agents. The typical combination of intravenous drugs is as follows: ketamine, opioid, benzodiazepines, propofol infusion, etc. So here we don't give any inhalation agent, we give only oxygen. If this technique is called TIVA or total intravenous anesthesia. When you take the ether, we expected ether to provide the components of good anesthetic plane. That is, we need amnesia. The patient should not recollect what has happened. Analgesia. The patient should not feel pain. The muscle relaxation. The muscle should not be rigid, interfering with the surgeon's work. So this is called triad of anesthesia: amnesia, analgesia, and muscle relaxation. So we expected ether to provide all these three. But the problem is slow induction, slow recovery, and it had side effects like explosion with the electrocautery. So now we are shifting to modern anesthesia. That is called balanced anesthesia. Mr. Lundy coined this term balanced anesthesia. What does it mean? We use more than one agents, that is multiple agents, so that less side effects will be observed for any drug. So we have the triad: amnesia, that is unconsciousness, hypnosis, and amnesia. They can be attained by IV anesthetic agents and followed by inhalation agents. So IV anesthetics are used as an induction. Inhalation agents are used as maintenance agents. Propofol can be used as an induction agent as well as maintenance agent when it is given as infusion. Then analgesia, we use opioid and nitrous oxide. Immobility or the muscle relaxation, we use separate group of drugs called muscle relaxants. So this causes reflex suppression from pain to movement, the reflex suppression. So we have now balanced anesthesia using multiple agents. What are all the challenges now? The patient is anesthetized. He had become unconscious and he has to become perfectly all right after surgery. For this, the central nervous system, that is the brain, should recover well. To recover, it should have got blood supply, adequate blood supply, and there should not be any disturbance in the oxygen delivery. How it is going to be made? So the respiratory system should be functioning well to provide oxygen delivery. Cardiovascular system should be functioning well to provide a good perfusion. Renal and liver should perform well to metabolize and excrete the anesthetic drugs. They should not have oliguria or hepatitis. So coming to cardiovascular system, how cardiovascular system can be affected? Anesthesia affects all systems. It interferes with all systems. It can increase the rate or decrease the rate, say bradycardia or tachycardia. It can cause arrhythmias. It can interfere with the cardiac output, causing hypotension, shock, or it can increase the BP also, hypertension. Then respiratory system. It can decrease the respiratory rate. If it is less than 10 per minute, we call it as respiratory depression and we have to intervene. It can reduce the respiratory excursion and functional residual capacity. When the excursion is reduced, functional residual capacity is reduced, there will be reduced gas exchange and there will be low oxygen availability. So this is countered by keeping minimum 33% of FiO2, that is inspired oxygen concentration. The other challenges are airway patency, protective airway reflexes, and the risk of pulmonary aspiration. Coming to airway patency and upper airway obstruction. So if the patient is sleeping, the tongue may fall against the posterior pharyngeal wall. The soft palate may touch the nasopharynx, thereby causing airway obstruction. But normally sleeping patient will wake up from the sleep, adjust by himself and correct it. So this partial state of obstruction, we call it as snoring. So the sleeping patient will have snoring, and now and then the patient himself, subject will wake up and get away from the snoring and again go to sleep, and this cycle goes on repeating. If the obstruction is critical, we call it as subapnea, and if the obstruction is total, then we call it as apnea. In anesthetized or unconscious patient, the patient cannot wake up or adjust the airway obstruction. So we have to do something. Otherwise, the patient may go for subapnea or apnea. The first one is manual method, triple maneuver, that is called chop face maneuver, head extension, chin lift, and jaw thrust. Then with equipments like oropharyngeal or nasopharyngeal airway, we are lifting the tongue away from the posterior pharyngeal wall, thereby allowing air to pass. So this is the oropharyngeal airway inserted through oral cavity. This is nasopharyngeal airway inserted through nose. Then comes endotracheal intubation. We are passing a tube beyond the vocal cords into the trachea. So we call it as endotracheal tube. And this procedure is called intubation. Oropharyngeal airway is less invasive. Endotracheal intubation is more invasive. And we have laryngeal mask airway in between the oropharyngeal airway and the ET tube. In the ET tube, it goes into the trachea, but LMA remains outside the laryngeal apparatus, just facing the inlet of the larynx. Oropharyngeal area will remain in the oropharynx. So LMA is in between oropharyngeal airway and endotracheal tube. And if you have difficulty in mouth opening and we cannot place endotracheal tube or oropharyngeal airway, then we go for tracheostomy. So this is airway maintaining below the vocal cords, that is infraglottic maintenance. All other we call them as a supraglottic devices, like LMA, oropharyngeal airway are called supraglottic devices. So tracheostomy is preferred when you are unable to maintain the airway patency with the other methods. Next challenge is aspiration of gastric contents. It can be a vomitus or a esophageal regurgitation. Generally, there are three protective airway reflexes. One is swallowing. Anything comes to oral cavity, the subject will swallow. Then the laryngeal inlet will go for laryngospasm, thereby obstructing the contents to enter into the trachea. If at all, if the contents pass beyond that, then subject will have cough. So this swallowing, laryngospasm and cough, these protective airway reflexes are functioning in a normal patient, normal subject. But if the patient is anesthetized, you cannot expect the airway reflexes to be intact. So the gastric contents can enter into the trachea and into the lungs. It causes Mendelssohn syndrome, that is called aspiration pneumonitis, chemical pneumonitis. To cause this syndrome, it needs minimum of 25 ml and a pH of 2.5. So how can we prevent? Ask the patient to starve 6 to 8 hours so that the gastric contents are less. Then we can reduce the volume by NG tube aspiration passed through nose, or a prokinetic drug like a metoclopramide. Then we can increase the pH to avoid aspiration pneumonitis syndrome by giving proton pump inhibitor like pantoprazole, rabeprazole, H2 receptor antagonist like ranitidine, non-particulate antacid. The regular magnesium sulfate and aluminum sulfate will not be used. We use liquid, that is non-particulate antacid, citrate solution. Then we can use a cuffed endotracheal tube or a tracheostomy tube. This cuff prevents the entry of gastric contents beyond the vocal cords. So the cuff will to maximum extent, it will prevent the entry of liquid beyond that point. Regarding endotracheal intubation, we should know the position of the patient. 3 axes are there: oral axis, pharyngeal and laryngeal. They are in different direction. So if we place a pillow, it causes neck flexion, thereby bringing laryngeal and pharyngeal axis in same line. Then if the extension of head brings the oral axis in line with the other 2 axes. So neck flexion and head extension is the position of the patient for intubation. So during a laryngoscopy, we will be able to see the epiglottis, arytenoid, aryepiglottic fold, false vocal cords, true vocal cords, and of course, the tracheal rings can be seen through the vocal cords. For this intubation, what we need? A good anesthesia. Either it's a intravenous like thiopentone or propofol, or an inhalational induction like halothane or sevoflurane. Halothane we are not using now. Sevoflurane is the preferred agent especially in children. And we should have a muscle relaxation. If there is no muscle relaxation, it can result in laryngospasm. So So attempting an intubation without a muscle relaxant and a superficial plane, then the patient will have laryngospasm, cough, etc. Endotracheal anesthesia was introduced very long back, 1878. The laryngoscope was invented in 1913, and they are modified by McGill, McIntosh, and Millers. The muscle relaxants are invented in 1942. Succinylcholine, they are synthesized in 1906, but used first only in 1950s. So you induce the patient either with intravenous or inhalation, give a muscle relaxant. Either it can be a depolarizing like succinylcholine or a non-depolarizing like a vecuronium and atracurium. The difference is succinylcholine produces muscle relaxation within 30 to 40 seconds. But the non-depolarizing relaxants take 3 minutes. Then mask ventilate, then do your laryngoscopy and pass the endotracheal tube. So if you are able to pass the endotracheal tube, the mission is successful. And there are 2 maneuvers to help the intubation. Burp maneuver is called backward, upward, and rightward. This pressure improves the laryngoscopy view. While the Sellick's maneuver, it is the cricoid pressure against vertebra. It compresses the esophagus, prevents aspiration of gastric contents entering into the pharynx. If the patient is not in proper starvation, the patient has a full stomach, it's an emergency surgery. So when the patient is conscious, there won't be aspiration. If the endotracheal tube is placed and cuff is inflated, there is a minimal chance for aspiration. But the period between the induction and placement of endotracheal tube, that 1 minute is very dangerous. So we can have aspiration. So the Sellick's maneuver prevents that chance. If you are not able to intubate, you have to go back to step 3. Ventilate with the mask and redo the laryngoscopy and try to pass the endotracheal tube with the help of bougie or stillet. But there is a grave situation where you are not able to intubate and you find it difficult to ventilate with the mask also. So in that case, the patient will go for hypoxia and may suffer cardiac arrest and death. What we should do, we can go for tracheostomy or a cricothyroidotomy. Tracheostomy is making a hole in the trachea. Cricothyroidotomy is making a puncture with a needle in the cricothyroid membrane. So this is the tracheostomy steps, and on the right side is cricothyroidotomy set and the instrument. After intubation, what we are going to do? We have to connect it to the circuit and ventilate the lung, check the air entry, inflate the cuff, and secure the endotracheal tube. Now, after confirming the position, the induction drug is going to last only for 5 minutes. So we have to initiate the maintenance with the nitrous oxide and an inhalation agent like isoflurane, sevoflurane, or desflurane. While giving nitrous oxide, you should also give oxygen with a minimum of 33% FiO2. If you have used non-depolarizing muscle relaxant, then it will go on for 20 to 30 minutes. Then the patient will partially recover from non-depolarizing muscle relaxant effect. When the surgery is going to take more time, a maintenance dose has to be given. Usually it will be 1/4 dose of the first dose. But if you have used depolarizing muscle relaxant like succinylcholine, it acts only for 5 minutes. So the spontaneous respiration will return. Now we have to decide whether we are going to maintain this spontaneous respiration with the endotracheal tube or going for a controlled, completely paralyzing mode. So if you decide to leave the patient in spontaneous respiration, previously we used to do for tonsillectomy. The patient will be on spontaneous ventilation with the endotracheal tube. There we are not going to give neuromuscular junction blockade agents. When the patient recovers from succinylcholine, the patient will continue on spontaneous respiration. But if you are going to use a controlled ventilation throughout the surgery, we change over to non-depolarizing relaxants. So nowadays, most of the patients, succinylcholine is not used directly. Non-depolarizing relaxant is used for intubation. Where we use succinylcholine, if we expect a difficulty in intubation, very obese, and if we expect a aspiration chance, then we use succinylcholine, then change over to non-depolarizing muscle relaxant. What are all the monitors? We have to monitor all the vital functions, organs. Pulse oximeter is the dominant one. It gives information about oxygen saturation and the pulse rate. So the oxygen saturation and pulse rate, it gives both information about cardiovascular system and respiratory system. If the heart rate can also be seen, arrhythmia to some extent can be seen with the pulse oximeter. It indicates good perfusion and it indicates the oxygenation. So there is a balanced assessment of cardiovascular system and respiratory system. Non-invasive BP, then ECG, then end-tidal carbon dioxide. End-tidal carbon dioxide assesses the expired air, predominantly the carbon dioxide in expired air, and tells us whether there is any difficulty in ventilation or sudden rise in carbon dioxide or sudden fall in carbon dioxide. Then we can monitor the neuromuscular junction. And in long drawn cases, we have to monitor the temperature, central venous pressure, intra-arterial blood pressure when we expect major blood loss and vascular shifts. Then comes the BIS, that is bispectral index. This is used for assessing the awareness or the adequacy of good anesthesia plane. Coming to circuits, the circuits bring the gas from the anesthesia machine to the patient end. We have semi-open circuits and circle system. In the circle system, we have soda lime, which comprises of sodium hydroxide and calcium hydroxide. It absorbs the carbon dioxide so that the expired air is recycled or reutilized. So there is economy of gas, less OT pollution, and heat and moisture will be preserved. The soda lime will have the indicator of exhaustion, so that when we should change the soda lime, it has been used for so long and it is no longer effective. The indicator will give the information that the soda lime has exhausted its function. So we will change. In case of semi-open circuits, the expired gas is vented out to the atmosphere. It is not recycled. So we need a higher flow, higher consumption of inhalation agents like isoflurane, sevoflurane, and there is more OT pollution. Heat and moisture are lost. So we have A to E, out of which A is called Megill's, E is called IRSTPs. IRSTPs is mainly for children. The Jackson-Ree modification of IRSTPs is the commonly used circuit for pediatric cases, anesthetizing the children. IRSTPs is not used. its modification by the Jackson-Ree is used now. Other coaxial circuits, the modified D is Bain and Penland. So this is the Bain circuit. And A is modified into LAC by providing coaxial tubes. So recovery from anesthesia. When the patient is on spontaneous respiration, you can have all these three types. General anesthesia with the face mask, no endotracheal intubation. General anesthesia with the face mask and oropharyngeal airway, still there is no endotracheal intubation. In both these cases, you wait for the recovery from nitrous oxide or inhalation agent. The patient will wake up, apply throat suction, and send the patient to the recovery room. So the patient will have baseline opioid action, say like morphine or pethidine or fentanyl. The baseline action will be there. Analgesia component will be there, drowsiness will be there, but the patient will recover from nitrous oxide or inhalation agent completely. Then you come to TIVA with oxygen supplementation. Here we don't use nitrous oxide or inhalation, so there is no question of recovery from inhalation agents. So the recovery depends on the drug what we use. See, opioid, whether we use pethidine or whether we use fentanyl or remifentanil, it depends on the type of opioid we use. Then it is benzodiazepines. Commonly midazolam is used, or diazepam also can be used. Ketamine is used for TIVA. We can also use propofol infusion for TIVA. So the recovery depends on the type of drug and the time of last dose given. In case of spontaneous respiration with the LMA or even endotracheal tube, first thing is we cut off the inhalation agent and the nitrous oxide. Then we wait for the patient to recover. We look for the recovery of consciousness, protective airway reflexes. If they have returned, we apply throat suction, remove the laryngeal mask airway or the endotracheal tube. But when we use controlled ventilation, you have used the muscle relaxant drugs, which have caused the blockade of neuromuscular junction. So we have to reverse the effects of muscle relaxants. What is the agent used? The neostigmine is the agent used for reversal. It is an reversible anticholinesterase inhibitors. It's a reversible anticholinesterase. That is, it is inhibiting cholinesterase reversibly. When the muscle relaxant dose is more, competitively, it can cause paralysis. When the neostigmine dose is more, then it brings back the patient from the paralysis. So when we use neostigmine, it reversibly inhibits cholinesterase. So acetylcholine level is increased in all tissues. It is unnecessary effect because if it increases in the muscarinic receptors like heart, secretory part of the GIT and upper airway, it results in increased secretions and bradycardia. So we use an muscarinic receptor blockers like atropine or glycopyrrolate to counter that. How do you assess the adequate recovery? Consciousness. The patient should obey your commands. If you say open your eyes, protrude your tongue, swallow, like that, if the patient obeys the commands, then consciousness is returning well. Adequate tidal excursion and respiratory rate, that should be there. The patient should not have very low rate or tachypneic. Sustained eye opening for 5 seconds, sustained head lift for 3 seconds, airway patency should be maintained, and muscle power recovery like finger nose test. We should ask the patient to lift his hand and touch the nose, finger to nose. And similarly, we assess the muscle power recovery. Airway patency maintaining, patient should be able to maintain the airway by himself. He should not expect our oropharyngeal airway or a nasopharyngeal airway or a laryngeal mask airway. Then coming to protective airway reflexes, the patient should have good swallowing and cough reflex. Then only we are very safe. So after recovery from anesthesia, we are not going to shift the patient to the post-operative ward. We are going to keep the patient in post-anesthesia care unit for 30 to 1 minute. So sometimes it may need 2 hours also. In the PACU, post-anesthesia care unit, we continue the monitors and we try to maintain the airway patency. If necessary, we will give oxygen supplementation. If there is necessity, then we will give a better fluid balance. This is the discharge from PACU. From PACU, you are going to shift the patient to the post-operative ward. So it cannot be an subjective. I may say that out of my experience, this patient can be sent to post-op ward. Not like that. We have an objective pattern. There are 5 parameters, out of which the top one will get 2 score. The other one will get score of 1. The third option will not have any score and will be represented as 0. So we have 5. So and the maximum score is 10. We should get 8, more than 8. That is 8 and above for sending the patient from PACU to the post-op ward. This is called Aldred score. So to summarize, general anesthesia techniques and agents, they either suppress or interfere with all systems. Eternal vigilance is the price of safety. So you have to monitor throughout the surgery and after surgery. That is the price of safety. That is the only thing which can save us. If you are going to identify the complications like hypotension very early, then the chances of damage to the tissues will be less. The recovery depends on the type of anesthesia and agents used. Like remifentanil and fentanyl, they may have a faster recovery, while pethidine and morphine, they may not have quick recovery. They may have a drowsiness. Then we have to apply preventive measures, and appropriate management of complications is essential for safe conduct. For the safe conduct, we should know all these things. These are all the resources: Anesthesia by Whaley and Anesthesia by Miller.